I'll be presenting a multimodality imaging conference today. If you guys want to log in to Poll Everywhere, this is the link. I'll have a QR code later on too, if that's easier for you. Okay, so let's get started. So this is a 54-year-old male who presents to the ED with fevers, chills, sore throat, and body aches. He has a history of CAD with prior PCIs, ischemic cardiomyopathy with EF last documented as 29%, for which he had an ICD placed in 2022. He also has hypertension, hyperlipidemia, diabetes, CKD, PAD with prior PTA, and a chronic left foot ulcer. So he's reporting 3-day history of fevers, 102, chills, sore throat, and body aches, as said earlier. He does note a recent positive strep test at an urgent care clinic. He otherwise denies any chest pain, palpitation, shortness of breath, lightheadedness, or syncope. Currently or recently, he sleeps with 2 pillows, which is his baseline, and he endorses no orthopnea. And he's really able to perform all his ADLs without any difficulty. He walks with his children several blocks to their school. So for his past medical history, just a little bit more detail about his cardiomyopathy. He's had this diagnosis for the last 18 years, for which he's been on GDMT. His last echo in the EPIC system was in 2022 with EF of 29% and no segmental wall motion abnormalities. These are his medications. He's on aspirin, Plavix, and atorvastatin. For his GDMT, he's on Coreg, Entresto, Clarinone, and Jardiance. He's also on digoxin, furosemide, hydralazine, Isodil, and glipizide for his diabetes. He has no known drug allergies. His mom has hypertension. His dad had diabetes. And he never smoked. He didn't know alcohol use. He was previously a security guard, and he's currently working as a doorman. So these were his documented vitals upon arrival to the ED. He was febrile to 38.3, mildly tachycardic to 102, soft-ish blood pressure at 99/63, and he's sounding well on room air. This was his documented physical exam per the ED. So he was well appearing, no acute distress. He did have posterior oropharyngeal erythema with no purulence and dry mucous membranes, no JVD. For his heart exam, he had normal S1, S2. He was tachycardic with no murmurs, and his lungs were cleared of auscultation bilaterally. For his extremities, he was warm, no lower extremity edema, and he has this shallow ulcer noted with no surrounding erythema or discharge. And alert and orange ×3. So these were his initial labs. His white count was elevated to 15.1. Hemoglobin was 12.8, which is down from his last hemoglobin at 14.4. For his CMP, his sodium was low 130, increase or high BUN and creatinine at 45 and 2.6. And he does have an AKI at this time with the prior creatinine being 1.32. His LFTs were normal. His COVID, flu, RSV, and strep were all negative despite the recent positive strep test. His A1C was 7.6. This is his lipid panel. And then his high sensitivity troponin was drawn in the ED. And it was initially 3,500, which uptrended to 7,400. And the BMP was elevated at 349, though he is on Entresto. So he was given fluids and his blood pressure improved. His repeat troponin downtrend is 3,500 from the 7,400, and an echo was performed at this time. So I have some clips of the echo. Dr. Krukar, would you be able to walk us through?
Sure.
Thank you.
So on the left, you can see there's a plaques image. On the left, you can see there's a plaques image where I think that one stopped playing, but the LV cavity is dilated. Severe LV dysfunction. My eye is definitely drawn to the inferolateral wall, which seems to be more severely hypokinetic, near akinetic, compared to the interseptal wall on the right. If you play that one. Difficult to see. I think there's some DEFINITY shots later, so I'm not entirely sure about the interlateral wall in this segment, but dilated LV and severely reduced LV systolic function.
Great. I have just one more image without contrast.
Okay, perfect. And again, without contrast, dilated LV, severely reduced LV systolic function, possibly wall motion abnormality in the inferolateral wall, but very difficult to see without DEFINITY. And I do see that device lead in the right side as well. All right, then we go to Definity, and on the left side, you can clearly see there's a hinge point, right at that apical lateral wall segment. So the basal to mid anterolateral wall is near akinetic. Again, dilated, severely reduced. I know you had commented that the previous CTE showed no wall motion abnormalities. And I guess you can go to the next clip. Again, here you can see the 3-chamber. I do feel that infralateral wall is hanging on more by comparison. So look like you have circumflex territory wall motion abnormality.
Perfect, thank you. So this was just the report. But yeah, so the echo showed new segmental wall motion abnormalities as compared to the prior echo from 2022. And his EF was reported at 20%, which is also down from prior, which was 29%. So at this time, the patient is started on heparin drip per cardiology consult, and he's planned for a coronary angiography. However, his blood cultures do come back positive with E. coli. He's noted to be hypoxic. His chest x-ray had patchy opacities, which is presumed to be pneumonia, and he was treated with antibiotics. But then he gets a left heart cath after a few days of antibiotics. Dr. Murphy, would you be able to go over the excellent cath films?
Thank you. Sure, yeah, so, as Stephanie said, we did this, I think probably 5 days after he came in, and he was chest pain free at this time. But these first shots are just the RCA. You can see proximally, there's really, there's some non-obstructive disease. There's a lesion distally that, we thought was significant. There's some disease on the PEA, and then there's a small RPL here that is diseased. If you go to the next slide. And from the right, we didn't really see any significant collaterals, but here on the first shots to the left, you see in the caudal shots, obviously he's had stents before. You can see in sort of the proximal part of what we actually call the distal circ, because there's a larger one that's branching before that. There's a very significant subtotal lesion that's just proximal to the stent edge. It does kind of, looks like it bleeds into the stent. So, we call that an ISR lesion. What you'll also notice though is that there's ISR in that big OM or ramus looking vessel. We know that there are 2 stents in that vessel already. And then as we go to the cranial shots, which may be on the next slide, you can see that there's a long segment of stent in the LAD and there's significant ISR in that stent as well, in an area where 2 stents had overlapped from prior intervention. So yeah, so that's what we call, it's really 3 vessel disease. There wasn't much proximally in the right. There was pretty bad ISR in the 2 vessels on the left, and we know he had multiple interventions. It was also at this point, as Stephanie said, many days after his initial presentation, he was chest pain free. His troponin had been downtrending for a long time. So rather than jump in and intervene on that subtotal circumflex lesion, we thought it would be better to leave it and have a heart team discussion, because it just based on the extent of ISR, it didn't necessarily look like he would respond very well to another intervention.
Thank you. But yeah, this is just the last left heart cath in the system from 2014, and just for comparison, you can see his mid RCA did progress. His PCIs his prox and mid LAD PCIs were placed in 2014, and now, as you saw, there was significant disease. And in 2014, the OM1 and OM2 were both patent, so significant progression of disease since 2014. So I'd like to take this time to ask everyone here, what would you do next for this patient? Would you medically manage? Would you, have Dr. Murphy do a PCI bypass or refer to CT surgery, or would you do viability testing? So yeah, this is the QR code. I'll just wait for everyone to finish.
Polev.com, Stephanie Jew. 406, if you're having trouble with the QR code. Go back to the slide for a second. I don't want people to get biased, A lot of people see responses come in, they get very biased. So let's give it like,
Be on the winning side somewhere.
give it like 20 seconds and then we'll come see, what everyone thinks. Then I also want to know what the panel thinks after the responses are in. We can go back now.
So it seems like most or half want viability testing. Third want or would refer to CT surgery for bypass, and some would medically manage.
So I'm just curious, before we get to the panel, how many of you chose viability testing because you heard that this case has to do with viability testing? Or how much do you, so raise your hand if you really think viability testing is the next step here. Just curious. Or people are just shy. All right, no one wants to put their nickel down. That's okay. All right, so let's get into the panel. So we see here half of the respondents said they want to go ahead with viability testing. We see there's severe disease here, severe progression of disease too, on really, really good therapy. We have 32% that said, cabbage, referred to Dr. Elishmawi here. I see, he's here, or just medical management, just continue what he's doing. This guy's walking his kids to school. He came in with what looked like a URI. He's walking his kids to school. He's doing well. The troponin seems, I don't know, it seems like it's probably demand mediated. There are some new segmental wall motion abnormalities. But who knows if these are truly new? Wall motion, as we know, is really hard to assess. So who knows? Especially, it's very hard to assess with an EF that low too. So what does the panel think? So we can start with Dr. Liao.
So this guy presented not with chest pain, right?
Right.
No chest pain throughout the admission.
So he comes in clinically presenting with what seems to be a pneumonia, some infectious process. We haven't had an echo. He has an echo now in this acute setting of his current illness. I think it is important to think about revascularization and viability, but I think in the acute setting, I would feel no urgency to do that, and treat what is going on primarily in the department first clinically, and then afterwards, I think the question of whether or not to revascularize is complicated, which is why Stephanie has presented the case. And then I think in that situation, once he's clinically stable, it's not unreasonable to think about viability testing. But as Stephanie will go over, the data are quite mixed. Maybe Dr. Murphy can tell us why he didn't put some sense in there.
Thank you guys for the 0% thing. We should do PCI. Makes me feel a lot better. I was thinking about this case last night. But no, I think, I hope that everyone agrees. I think, as Dr. Liao said, it was not a syndrome that was suggesting ACS, true type 1 and STEMI. He was quite septic when he came in. He was on high flow for a long time. I think by the time we got to him, I felt pretty comfortable that we were out of the window where PCI, up front would really help in any of his outcomes. And so, my approach was I wanted kind of like Dr. Liao was suggesting, a more reasoned discussion, seeing, what our indications for revascularization were after he got through the acute illness.
Yeah, so he was already referred to me at that point. So I was thinking section 3, but once I saw him, I knew this is not going to be my decision because the patient has low EF, has long-standing cardiomyopathy. I guess in the history, you have to go back to 18 years ago and look at the echoes to see whether this EF is better or worse than before. So you can have a sense of where you are at this point. But what I would choose is basically can end it as an option 5, which is a hard team discussion because that's what ultimately going to decide what to do.
Thank you. I agree that the patient didn't present with an acute ACS, and I'm happy that everyone actually chose viability testing with what looked like a relatively thin wall and focal akinesis, because that actually doesn't predict potential for future recovery of LV function. So I think in this case, it was reasonable to treat his sepsis and then consider viability testing. And I agree with Dr. Liao, maybe not even necessarily immediately. And there are downsides to actually doing that. So for instance, with doing an MRI, potentially in a possibly acute setting, you might actually falsely kind of overestimate the amount of quote unquote fibrosis because it might be an inflammatory setting. So I agree with viability testing down the line.
And just Dr. Elishmawi, a lot of viability testing recommendations comes from cardiothoracic surgeons. And I just want to get, now that we're on the topic of viability testing, obviously we're going to get more into it and the intricacies of it. But what's your stance on viability testing? When do you tend to go for it? Do you trust it? What's your overall sense of viability testing as a surgeon?
My main question in this patient, this is a complex case because we know the patient doesn't have angina. So if we take this patient to the OR, we're literally looking for improving his long-term survival, right? And the long-term prognosis. So we have to have some objective evidence that this is actually high likelihood to happen, especially knowing that the perioperative risk is high in these patients. So we're gonna pay a big price up front for sort of unknown outcome, or there has to be some evidence. So I would say a positive viability study would be more assuring to me, not necessarily about also the prognosis, but about the perioperative improvement of myocardial function, which will determine the 30-day mortality in this patient, because we know this low EF will be correlated to high risk. If you don't have a viability, then the question or the decision to do CABG or surgical revascularization becomes a much tougher one to do.
What about the stitch trial? Stitch trial did not suggest that, but you need viability.
Yes, and we know that it was a negative trial.
No,
have to-
yeah, bring it up the point because
We can go on the limitation of that trial, long way, number of patient, what kind of viability you use, durability, how long you follow the patient, etc. And I guess the stitches trial that came later showed, some evidence that CABG would be important. My main question, why you do viability? From first to get some evidence, because we're gonna be questioned about why we did this case. Second, the mortality, the risk. Because even if the patient doesn't improve in the long term, I don't want the patient to die within 30 days of surgery, because that would be a disaster in young patient who have no symptoms. And when you go back to the history, you find that 18 years ago, the patient has EF of like 15%. So this is sort of the question I had in this patient, whether does he have true ischemic cardiomyopathy or non-ischemic cardiomyopathy with added on coronary artery disease.
Thank you.
Thank you. So, as mentioned, CT surgery was consulted. They felt that the patient was stable from a cardiac perspective, and then he was just treated for his bacteremia and discharged with a plan for outpatient follow-up. And then he was seen in cardiology clinic, where he continued to be doing well. He remained asymptomatic, and he was recommended for a viability evaluation. So
Can
second,
I just go back? So there were two clinical points. One is because he had AICD and then bacteremia, I need to be concerned about whether he had endocarditis or not on the device. Because it would have been catastrophic if he did. So hopefully that was looked at carefully. And the other thing is the consideration of compass dose, low dose of Xarelto and aspirin in this guy who's a multi-bed vascular path may have been really worthwhile.
thank you. But now second poll everywhere question, what viability testing would you order? CMR, PET, dobutamine stress echo, or SPECT?
His creatinine is what?
It was like 2.6 from 1.3.
Yeah, he has an AKI right now. Let's,
Yeah.
thank you.
I'll hide it.
Yeah, we don't want to cloud any
No
judgment.
bias here.
This, while people are voting, this to me is always a very interesting thing, Like, I obviously love MRI, so to me, I'm like, oh, MRI is the best, right? But then I have a feeling there might be some other people on the panel that may see other things. I know Dr. Liao has a very lively line about this that he'll talk to us about, but and I know the echo people out there might say, oh, so Let's see what people responded here.
Pet, 100%.
Wow,
Wow.
wow.
That could be one person or everybody.
I didn't see Dr. Liao voting, so it wasn't him. He wasn't the one person. Oh, whoa, 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 whoa.
So just a glitch, sorry.
Oh, my God.
Election.
Maybe I said something to shift the scales here, who knows? Tried to be pretty, even on it. All right, so I mean, to me, this is a very interesting thing, and I love these multimodality discussions because we have imagers, we have, nuclear experts, and we have the interventionalists and the surgeons here, all of which I'm very curious kind of what they prefer in terms of viability testing. What do you trust the most? What do you think is the best? And, Dr. Elishmawi was mentioning, some of the trials use some viability testing over others, so, maybe you can trust, some more than others, and kind of where does that come from? So let's start with 100% pet, Dr. Liao.
So, first of all, I love all imaging. Yeah, just let me say that for the record. Yeah. I think it really depends on how we define viability. I would say the different modalities, I would say, look for evidence of viability in different ways. For example, an MRI, and Stephanie might be going over this in more detail later. We're really looking for evidence of death. So that would be myocardial death with fibrosis, so replacement of myocardium with fibrous tissue. In PET, we're looking for evidence of metabolic activity, so that would be evidence of life. So looking for evidence of death versus evidence of life with dobutamine, you're looking to see, in addition to evidence of just metabolic activity, you're looking to see if there's any functional improvement with recruitment, with increased adrenergic tone. And then SPECT is similar to PET in that it's looking for evidence of life with the presence of intact cell membrane and the ability to take up and retain technetium. So I think that they're all answering sort of different questions, which I think leads to some of the confusion and data disparity in the various viability studies that you're going to be presenting.
Yeah, just for interventionalist, surgeon, what do you trust the most? Actually, no, let's get another imaging, let's get another imaging perspective in terms of, obviously we have two multimodality imagers here. What do you think is the best, with your experience of reading these different things? And then I definitely want to get the interventionalists and surgeons' perspective on what do you trust the most?
I think Dr. Liao summarized it perfectly, and I think the reality is we're looking for different things in different modalities, and essentially CMR is looking for gadolinium, retention in extracellular matrix. So that could be in the setting of inflammation or fibrosis, which is why, again, in the acute setting, you might have increased gadolinium deposition. That doesn't necessarily mean we're answering, what we're really looking for in this room is will this patient recover function? And the reality is all the imaging modalities are looking for different things. Like with CMR, I'm looking for increase in extracellular volume and deposition with the fibrosis. With PET, I'm looking for direct metabolic activity, right? So specifically with the uptitration and that glucose transporter that Dr. Liao can better speak with. And the question is that going to predict functional recovery? Or am I just looking for cells that are alive? And dobutamine stress echo, I know that has much higher specificity, but you might miss myocardium that's actually viable and will recover function. And that was one of the major criticisms of the Stitch trial from 10 years ago, which I'm sure many people in this room can speak with better than me, but the original trial was looking at dobutamine and SPECT and not particularly looking at kind of the more advanced viability imaging techniques. So I can't, I love CMR as well, but I do think there is value to be had with all the modalities.
Just before that, what do you think about, you mentioned the specificity
Right.
of dobutamine, which is really great, and I think a lot of that comes from that biphasic response that you see with these dobutamine stress echoes. And there is a lot of good data about the biphasic response. Are you able to just speak about that and kind of?
Sure. So biphasic responders for the fellows in the room are with low dose dobutamine, you see, contractile reserve, you'll see improvement in function, and then you will lose it at higher dose dobutamine, so then you will develop akinesis. We do know that in severely ischemic territory, that sometimes even with low dose dobutamine, we're not able to recruit those myocytes, but there are, Dr. Goldman probably will, better comment on that. There are protocols where you'll have like a longer term of low dose dobutamine to recruit those myocytes, but the specificity is very high for dobutamine echo. However, you lose a little bit of sensitivity with doing that test. So you don't want to lose the potential to identify the patients that might actually have true viability. But when it is positive, it's very helpful. That's helpful.
Can I make a point?
Yeah.
Can I make a point? I think that these are great questions. I think the most important is the expertise of the team. And of course, here we have all the expertise. So, because these tests conclusively, they should give you the same answer. Otherwise there would have been a preference of one or the other. But as you see, the list is still all of them. So I think it depends on the protocol that you use and the expertise of the people who read them. And with all of them, most of the time, should come into the same conclusion. Of course, biphasic response of the vitamin, we know the people that who do this is more difficult, to see if the wall will get better and then drop down. But MRI and PET is more easy to read, compared to see the biphasic response of the vitamins. So I think, in all the, we should come to the same conclusion. It's whichever you use, So that's my point. It depends on the expertise. Of course, here we have all the expertise. That's why it's more complex.
Yeah, I mean, and just to follow up on that, there is a level, maybe not. When I read an MRI, there's a level of subjectivity. I don't want to say anybody else, but when I'm reading an MRI, there's definitely a level of subjectivity, especially when you have a lot of scar. And so parts, we here read it qualitatively. Obviously, there's quantitative ways for measuring LGE and scar. Most centers do it qualitatively. Just looking at an area, how much do we think it is, right? And I think that's so important because we know, and Stephanie's going to show the data, that even 25 to 50% of the myocardium, quote unquote, having, like just 25 to 50% LGE, so less than half of that territory having LGE, the data is still not great in terms of recovery, right? It's about 40% in that subset. And so some trials, like there was a trial that Stephanie just talked about, which was a subgroup, pre-specified secondary analysis of the BCIS revised trial. Yeah. They used a cutoff of 25%, right? Because of that, because it goes from 60 down to 40 in terms of the percent, recovery that you would expect with the amount of scar. But it is subjective. It is very subjective. And that's why I always find it very helpful when we discuss it with the surgeons. We look at the images together and you make kind of a heart team discussion on it, which I think is so important. And that's why this is the heart team sitting right in front of us right now, which is really amazing. So Dr. Leah.
I just wanted to comment on that trial and the difference between that and the Stitch trial. We can always find criticism for any of these trials. I mean, the criticism of the Stitch trial that Dr. Kukar pointed out was that it was criticized for not having MRI or PET. And then the PCI study did use MRI predominantly. And for me, that study decided to use a 25% cutoff for viability instead of a 50%, which was typically what we would use here. So then you wonder, and the other criticism for the Stitch trial was that they didn't include as many people in that trial that did not have viability. So statistically, it was hard to make sense of that trial, given that most of the people in that study allegedly had viability. So in this particular case, now they've lowered the threshold for viability, and they still were not able to show an improvement. So I think it's like a moving target, and the different modalities look at different things, and the definitions of viability within the imaging modality also change. So it's just a complicated field.
All right, let's get to the interventionalists and the surgeons. Let's hear about your take on viability, the different modalities, and obviously, how it relates to the case.
Yeah, I'll be quick. I think from a PCI perspective, the data really is from the Revive trial.
Right.
that used mainly MRI and bubutamine. And again, that did not show any prognostic significance of either viability modality in terms of positively commenting that there was viability. There was an association with poorer outcomes for higher proportion of non-viable segments in that trial. And again, the intervention in that trial, PCI made no difference whatsoever. So, I think from a PCI perspective, I probably don't have much of an indication to viability. But our upfront intervention, as Dr. Elishmael was talking about, there's less risk involved in that. So, we maybe don't feel the need to pull in as much data before we embark on something, And also, we're doing it for a different indication. We're doing it for angina. We're not doing it for LV recovery because we don't have data for that.
Right, and the other thing that you mentioned was, it was a little bit of is this truly fully ischemic cardiomyopathy? Is this a mixed process? And an MRI is a really good test to kind of try to parse that out.
Yeah, that was basically the reason I technically requested an MRI, because I want to exclude any non-ischemic etiology, because that would be a decisive factor here. Also, the scar burden, because the outcome is not going to be favorable if you have high scar burden. Also, I think every test sort of give you a different prospect, so I wouldn't underestimate the dobutamine, because for me, the presence of myocardial reserve is important. This patient will come out of this surgery on probably high doses of catecholamine, so I want to make sure that they have some degree of myocardial reserve that will sort of increase the safety of the early events, because we know that mortality in this patient in the STITCH trial was over 5%, about 5%, including patients who died during surgery. Again, that can be also modified by advanced, mechanical support. But my goal is, if I'm going to do the CABG, I have to get the patient out of the OR as much as I can without any sort of mechanical support, because that will impact the outcome. So I guess a combination of MRI and dobutamine.
I think also, this is a random kind of question, but we talk about this in CT just in terms of the anatomic ability to revascularize. So in CT, they talk about blunt stomp, presence of calcification, whether it's tapered or not. I mean, I think part of the question also is even if it's viable, is the anatomy favorable to potential PCI or not? And I mean, I'm not an interventionalist, so I'm not sure, just looking at that cath film. Obviously, we have the best interventionalists in the world, but I do think in this case in particular, didn't seem quite like an easy, relative PCI. And I do think that also comes into play, whether there's viability in those segments or not.
Right, and the other question is, right, but in 2014, all of these arteries were opened and the EF did not budge much. So I think that also is a little bit of an indicator that there was kind of full revascularization of these affected segments without a lot of recovery. So maybe that is also a little bit of a tell here as well. But definitely, I mean, how bad are these CTOs, how calcified, the stumps, all those things. And then the ISR2 with 2 layers of stent already. Again, I'm not an expert in this, but it seems like it would be a difficult task. Would you agree?
Yeah, I think the PCIs themselves, these are all pretty focal lesions. The PCIs themselves would certainly be technically doable.
It's a piece of cake, yeah.
Yeah, exactly. But I think for me, the question just was, he's had multiple PCIs before. He's shown that he has, he's had a lot of reinterventions on the OM and the circ. The LAD is already, restenosed, albeit after, 6-8 years. The question is, in a really young guy, is, putting in a technology that's likely going to restenose again, in another 8 years, say, does that make any sense?
And would you consider this 2-vessel CAD? Or would you say this is, I mean, the guy has diabetes and we're the home of the freedom trial and everything.
Those pictures you can really see. The distal RCA lesion was significant. Again, that was a focal, simple lesion. There's relatively low syntax if we're getting into it, but he definitely was, 3-vessel diabetes. And again, we were thinking about what would be the more durable solution. And I think PCI probably, just based on history, wouldn't be that.
I just would say to the fellows that this is an example 10 years ago, maybe why cabbage might have been a better option then, is that we don't have to be worried about the complexities of ISR, 10 years later.
Awesome.
Yeah. So we see the images here.
Yeah, thank you for the wonderful discussion. I'll just skip over a couple slides that I had to discuss viability, since we had a great discussion already, and pull up to the first viability study this patient had, which is a PET. This is in color and this is in black and white. Dr. Liao, would you be able to walk us through it?
Sure. So PET imaging, in contradistinction to what the fellow here SPECT, uses positron emission, and it images coincident gamma radiation strikes on different sides of the PET scanner at a higher energy level. So as a consequence, KEV, as you all well know in this room, being on my rotation, is 140 for technetium, but for something like rubidium or FDG, it's up into 500. So a higher KEV means that it's able to penetrate tissue better, and so therefore it's less affected by things like attenuation. On the first row is perfusion. The common perfusion agents historically are rubidium and ammonia. There's a new agent called flopiridaz, but this one's probably done with either rubidium or ammonia, probably. Very short half-life, and the perfusion is exactly very similar or almost identical to kind of what we're looking at on our technetium scans here. We're looking to see if there's areas of flow or decreased flow in certain areas, and I would say that you can probably see that in the lateral wall, particularly in the apical four-chamber. You will see that the lateral wall is a little bit darker than the septum, for example, and you can see that on the short axis slices perhaps as well. And then the second line is FDG. FDG is glucose metabolite, and so as Dr. Kukar said before, we're looking to see areas where glucose is metabolized. Under normal conditions, the myocardium metabolizes free fatty acids preferentially, and in areas that are in distress with ischemia, it switches to predominantly glucose metabolism. And this is a bit of a complicated thing to do in someone who's a diabetic like this gentleman is. They typically like to use a euglycemic clamp to make sure that there is a constant glucose level so that the uptake of FDG can be maximized. But actually, I think you can see here that in the bottom row, it's basically the mirror image of the top. The lateral wall, you can see, gets a lot of uptake of FDG. So this is so-called mismatch between perfusion and FDG. So that would indicate, for example, an area of decreased flow with increased metabolism of FDG, which means that it is under distress and therefore preferentially metabolizing glucose. So viable.
Great, thank you. This was just the report, but basically, as Dr. Liao had said, the PET does show some viability in the left circ territory. And so he is seen in a CT surgery clinic, and he was planned for admission for evaluation of either high-risk bypass or advanced therapy. So he has several things done when he arrives to the hospital. And first, he gets a right heart cath done. Dr. Murphy, would you be able to walk us through this?
Yeah. I think, the upshot is that shows that he's fairly well compensated, even despite his significant LV dysfunction. The numbers are pretty normal. His cardiac output is low normal. So that's just a sign that the medical therapy is working, and that, that sort of coincided with his clinical presentation.
Thank you. He also gets a CPET done because they're looking for some objective evidence that maybe this patient could have poor survival prognosis. Dr. Liao?
Okay, so the caveat is I'm not a CPET expert, but I will tell you that the things that the heart failure team looks for are the peak VO2, which is oxygen consumption and cardiac work, and numbers less than 14 over there in terms of measured as milliliters per kilogram per minute, carry a worse prognosis and a better indication for transplant. The R value is a respiratory equivalent ratio, so that's the VCO2 or VO2. As we exercise, everyone will reach an anaerobic threshold where the production of VCO2 outstrips the ability to use O2, and that's typically when on the treadmill everyone starts to feel like crud. And so that ratio of 1.1 would indicate to us that the patient achieved a good enough effort on the treadmill. So this patient got 1.35, so that's a good effort. 14.4 is technically above 14, but just barely. And then the other number that carries prognosis is the VE-VCO2 ratio. And his VCO2 ratio peak is 39, which is greater than 34. That also carries prognosis in regards to heart failure and possibly benefit from transplant.
Great, thank you. And then finally, he gets a cardiac MRI.
Sure, so these are the cine, so these are the cine images. You can see, again, just kind of confirming dilated LV, severely reduced LV systolic function. Maybe on the bottom left, you can kind of appreciate that the anterolateral wall is near akinetic. Pretty good images, actually, for someone who has a device. Kudos to you guys for that. I think you can move on to the short axis. So again, we kind of slice down in 8mm slices and, oh, seems to stop playing.
Sorry.
You can see that there's some thinning of that anterolateral wall actually on the short axis images here, which again, I just want to emphasize is not a sign that that wall will not recover. And I think that's been well disproven in the literature. So wall thinning does not necessarily correlate with lack of viability. But there's definitely a hinge point with some regional wall motion abnormality here. I think we can move on to the next. Okay, so this is delayed enhancement imaging. So as Dr. Liao and Dr. Beanstalk mentioned, we're looking really for 50% kind of enhancement of a specific territory, specifically meaning the thickness of a particular wall. In this case, as you kind of march down from the basal to apical segments, it would say you've got, 1 to 25% enhancement of the basal anterolateral wall, maybe getting up to about 50% in the mid anterolateral segments. And certainly I think it's about 1 to 25% possibly in that mid infralateral segment. As you can see, they're actually, with bright blood imaging, which is what this is, sometimes it can be difficult to assess the amount of thickness, and I do know there are some centers who are actually doing and working on some black blood delayed enhancement imaging to better assess this. But I would say that this is about a solid 50% at the maximum. And as we kind of commented before, even at that level, it's about a 40%, viability. So it's a continuum. It's not a dichotomy, which doesn't make us happy as cardiologists to not be able to definitively say yea or nay. But I would say that this is a 50%. I would not necessarily not call this viable. And I think this is kind of one of those borderline segments which potentially agrees with the PET. I think you can move on. So there is one segment here, in the on the left side, obviously you see what's essentially an apical 3 version of echo. I do think that basal to mid infralateral wall is viable. You do see maybe 1 to 25% thickness of that enhancement. In the middle section, you see a 4-chamber where possibly maybe you're getting to 50 to 75% on that mid anterolateral wall. Like Dr. Beanstalk mentioned, there is some obviously reader opinion variability, and the quantitative techniques versus an experienced reader probably quite similar. And on the right side of the image with the 2-chamber, maybe there's a focal 50 to 75% in the mid inferior wall, which would probably be the only segment I'm convinced may not be viable in this setting. But again, we do know that even with the patients with 50 to 75% but almost transmural infarct, that not 100% of them will not be deemed non-viable. But again, that would be maybe less than 10%. So I would say that the vast majority of this may be viable with some small focal territories, mid-inferior and mid-anterolateral, that may not recover.
Great, thank you. So this was just the report. Oh, okay, sorry, I thought you were gonna say something.
Yeah, not yet.
Okay, but yeah, it was actually read as potentially more or less viable than Dr. Kukar had read, but I'll just kind of skip over. Or
So I think again, there is some I tend to agree with you, as to the way that you read this. I think the majority of the segments look pretty okay. And again, okay is probably the operative word there, because we know, again, is this 48%? Is this 55? Again, as you mentioned, it really is a continuum.
Right.
We're doing this qualitatively over a segment here, but if I look at these images, I think, you know what, the majority is probably viable. There are some areas, maybe in the lateral wall, infralateral, maybe a little anterolateral, maybe in that focal area in the mid-inferior. But again, there is some level of inter-reader variability. The other thing is that the PET looked like very viable, right? The MRI is like, it looks pretty viable, but there are some areas that don't look that great, in terms of that 50% cutoff, which again, we might be even going towards a 25% cutoff in recent studies, as we mentioned. So the question is kind of, right, it leads us to this next question is, what viability testing do you trust more? Do you see this PET and you say to yourself, wow, that is very viable, and I'm just gonna go by that? Or do you look at this MRI, again, PET shows life, right? MRI shows death, right? So am I gonna believe in life? Am I gonna believe in the death of some of these areas? So which one do you trust more? You've heard our discussion now. Let's go to poll everywhere. You've heard the discussion about the different modalities. You've heard of the life and death argument. Which one do you trust more? And then we'll discuss it. I really like that when you said that, right? Really, it hit home, okay, obviously. It hit home. So which one do you trust more? We also showed a nice graph earlier about the sensitivity, specificity of each modality as well.
The book of Steve,
Yeah.
yes, I like that.
I just want to say, some of you that rotate on nuclear are sort of put off by our lack of spatial resolution, let's put it that way. And I think that this is a good case to illustrate that even though MRI has possibly the best spatial resolution, it doesn't necessarily always make the final answer that much clearer to figure out.
All right, so let's take a look.
PET, pretty much 2/3.
All right, interesting. So let's hear what the rest of the panel thinks about that. Again, which one do you trust more in general versus which one do you trust more in this case might be different. But again, as we mentioned, really taking these modalities in a case-by-case basis is probably the way to go, and personalizing it to each case is probably the way to go. But let's hear from our expert panel.
The one thing I would say is these two studies were done a few months apart, so I don't know from the experts in the audience if that actually could make them more internally consistent, if that's a move from hibernation to infarct. I don't know if that's possible.
You're increasing the MRI as you were talking. MRI went up. Interesting.
Well, I would always interpret that based on the coronary anatomy and how dilated is the ventricle, because the MRI showed that this is severely dilated LV. So I guess we talk more about, we have to consider the LV volume, because that has been even more sensitive than the ejection fraction in predicting outcomes in these patients in some of the studies. So if you look at try to correlate the coronary anatomy, I guess its best target is the LAD, because it's a big target and tight lesions. That doesn't go with the RCA. The RCA is a moderate lesion. I know it's probably positive in your studies, but again, the graft patency will be questioned in that RCA because it's not a very tight lesion. And those patients will never tolerate any graft failure early post-op because they don't have any reserve. And the circ is not a good, it's a CTO, you might find it, you might not. So again, we have some questions about how successful you can go complete revascularization in this patient. So based on that, I would be more leaning to believe the MRI because it's not clear for me that the patient has strong evidence that it will benefit from surgical revascularization, knowing even the surgical risk of harm.
Well, I agree that I actually don't think that they contradict each other. I do think there are, like Dr. Bienstock said, there are some focal areas of the MRI that potentially maybe partially ascribe to the better spatial resolution, which is good to see the size and the complete extent. But I kind of go back to the question of, you know, if we know that the myocytes are viable, and they are utilizing glucose, does that necessarily predict functional recovery, which is ultimately what we are after. So I think there's no question that there are myocytes in that territory that are alive, but obviously CT surgery has far better experience with whether that predicts better functional recovery after revas, which is not without risk.
I would like to make, sorry for my voice, but I would like to make the point that for me, both tests show the same thing. It's more obvious with PET, less with MRI, because MRI is a little bit more technical. But PET shows viability, MRI shows that for sure you cannot tell that the wall is not viable.
Yeah, I
So,
agree.
no, I want to make this point because the least we want to do here is to go and do 3, 4 tests for everybody, you know. I mean, because these modalities in the best hands should show the same information. So, to me, both tests show that the lateral wall is viable. Maybe less viable, maybe few areas with MRI, they are not, but the whole wall is viable. So, just want to make this point because otherwise, we'll, you don't like the MRI, let's do PET. Let's do PET, we don't like the PET, let's do biphasic response.
Right. No, that was my whole thing too, before we looked at the images, and we saw that the PET and the MRI are probably pretty much in lockstep. But on the face of it, if you don't review the images, you think that they're in opposition to each other. And so you might get into that rabbit hole of saying, let's do dobutamine now, let's go in for the clincher, let's see what's going on, if you're really interested in opening this up, which it doesn't seem like that's the case. But again, yeah, I don't think a few months is gonna make a huge difference here between the modalities, to be honest. And in terms of Dr. Elishmawi's point, very dilated LV, and all the scar looks ischemic. You know, obviously with some dilated cardiomyopathies and cardiomyopathies due to other things, you can see some non-ischemic scar, and it doesn't seem like we saw that here.
Dr. Stern?
Dr. Elishmawi brought up, what, thank you. Dr. Elishmawi brought up, unless I misunderstood, what if this is not ischemic?
Right.
That is, if you bring more blood to something that's not ischemic, it's not gonna work any better. And I'm open to your thoughts. We don't have a great test for things that are not ischemic. We can tell you if it gets blood, we can tell you if it's dead, as you heard here, metabolically active, but stuff that's metabolically active and lacks oomph is gonna look the same as, anyway.
The
best test we
MRI
have
is
is
actually
MRI,
the best
yeah.
test, yeah. I'm
But
sorry, I
what does
didn't
that look
mention
like for
that.
non-ischemic?
So it would be,
Myocardial pattern.
I'll
I'm thinking like things like ethanol or other such things, not that he has that, just things that, or, deficiencies.
Yeah, no, and I'm sorry, I didn't mention that actually, but MRI is actually a good test just to differentiate between ischemic or non-ischemic. And if you go back, sorry, to the delayed enhancement images, you can see here, any of them are good. You can see here that it's clearly involving the subendocardial border, and it's not sparing it. So typically, in this pattern, we know that this is due to ischemic heart disease, right? Obviously, the coronaries run epicardially in the first area to kind of see lack of blood flow and infarct would be the subendocardium. The mid-myocardial pattern of enhancement is the wash basket of several disease patterns that could be, as to your point, a non-ischemic pattern. So I do think we know that this is an ischemic cardiomyopathy. But again, to Dr. Beanstalk's point, we don't know why with full revasc in the past, he didn't really fully recover. So I do think it's a good point to look for a non-ischemic etiology as well, which in this case, it doesn't look like he had based on the MRI.
Great, thank you. So just quickly, so this patient, as we said earlier, was completely asymptomatic throughout. His right heart cath showed pretty good hemodynamics. CPET showed pretty good, or above 14 for the VO2 max. So just very quickly, what would you do next? Would you medically manage or would you revascularize this patient with all the information that we know at this point? Let it run for a couple seconds.
We have 3 minutes. Oh, okay. Yeah, so I guess, Dr. Rackus makes a good point. We have a bunch of people joining us on Zoom. And now is a good time while this poll is ongoing here, If any of the other sites have any questions for the panel, or anything that they would like to add to the discussion at this point, we're open.
In the meanwhile, I'm just gonna give you the surgeon perspective.
Yeah, sure.
Because I have seen these patients over the last almost 20 years. It was a common encounter, I would say 15, 20 years ago, that you get a call from the OR that the surgeon did a bypass and he cannot come off bypass because the ventricle just didn't tolerate the cross-clamp, especially if you have to do like a mitral repair or whatever. I should say now in 2024, that became almost unknown event or extremely unusual, especially in big centers like here. The reason for that, I think, because we are getting very good imaging, so we can select those patients. So we have some selection bias because that's why we don't see patients, we take them for revascularization and then, because CABG is not like a PCI. The CABG is much more traumatic surgery to the myocardial than just a revascularization of the cath lab. So I think we are getting much better in selecting this patient because of the imaging. Also, one final comment is, you have to think about not only the perioperative mortality, but you have to compare the 10-year outcome of a CABG versus the 10-year outcome of a heart transplant, because we have very solid data on the transplant. The 10-year survival will be over 75% of these patients. So we have to come up with a very good argument if you're going to go with surgical revascularization in that particular patient.
I don't know how we can check if there's any questions.
Well,
Yes,
anyone,
excuse me, what exactly was the medical management and what were the targets they were aiming for? Because, you know, it's a little controversial. It can be, at least, what is optimal medical management for this person?
Wait, sorry, I didn't
what's
hear.
the optimal medical management?
And what's he getting it?
I mean, he was on pretty good medications. His LDL was well controlled at 41 on his atorvastatin. He was on aspirin, he was on Plavix, he was on all 4 GDMT. And on top of that, he was on hydralazine,
I think
Isodil,
he was on
digoxin, he was
full-
everything.
He was on everything.
Maybe some medications could have been a little bit higher, but he was on.
Yeah, I mean, the question could have been, the only question is that, you know, would you intensify, and again, there's Dr. Botts here, but would you intensify P2Y12 inhibition and other things like that when you see that there's various ISRs and, you know, would you go to Brilinta, would you go to Prasugrel? Is there any role for that? That's the only thing that I can think of in terms of. Right, or compass dosing.
I mean, if it was clearly in-stent restenosis, I walked in a lip,
Yeah.
if it's clearly in-stent restenosis, there's really no data that more potent antiplatelet therapy mediates it. I mean, something that was studied in the late 90s in terms of potent antiplatelet, including coronary intravenous, and doesn't actually affect platelet adhesion. Animal models show that platelets are really important in restenosis, but none of the human studies have validated that. Of course, sometimes you can't tell in real life, is it restenosis, is it thrombosis, but it doesn't sound like that was the case here.
So then, to answer that question, he was on the best therapy then. Yeah.
I think that the medical treatment is a great choice for this patient because it almost satisfies a lot of what we can achieve by revascularization in that particular case. It has antiarrhythmic effect, it will prevent readmission. The patient was completely asymptomatic.
Right.
You see the right heart cath, almost like a normal walking patient. So I'm not sure how much better you can get from this.
Yeah, makes sense.
Great.
Dr. Pat, any comments? I know you have done reviews on the stitch trial, so.
Well, I mean, it's tough, you know. Between Stitch and Revive, you can basically conclude whatever you want about viability. If you're a believer, do it. If you're not a believer, don't. I mean, I think back to something Bruce Lytle, who used to be head of cardiac surgery at the Cleveland Clinic, used to say, you know, he said he didn't really need any sort of viability testing, but if it made us happy or, you know, made the medical chart happy, then to do it. But, you know, his feeling was if there was angina, that those folks would always recover LV function. If there was absolutely no angina at all, that the likelihood of LV function recovering in the case of LV dysfunction was really kind of low. And I think there's probably some wisdom to that. I mean, of course, you can find some exceptions.
And on the CPET, I don't think he had any chest pain either.
Yeah, so that's a great point. I mean, for us as a surgeon, chest pain means you have a viable myocardium. I don't care what's the viability study. So that's prompted everything else, which is take you back to the history and how the patient presented.
Is that medical? Is that medical?
Yeah.
Great, so I'll just finish up really quickly. This was a proposed algorithm for how to manage, ischemic cardiomyopathy and the use of viability. Oh, did you have a question?
I was just wondering, so in this patient where you had someone who had sepsis, had a high trope, maybe not ACS, but then on viability imaging, it seems like there's one territory, one vascular territory that's quote unquote threatened. It's alive, but it's not getting good blood flow. And then they went to the surgeons because of multi-vessel disease and first surgical consultation. Maybe not the best candidate, graft failure, technicalities, you name it. Would there be any role at this point for PCI since there's one specific target you can maybe hit?
I'd be interested with Dr. Bott or. Yes.
I mean, so the thing that I've been thinking about while this conversation's been going on was he's a diabetic guy that had multi-vessel PCIs. EF has always been bad. He's on optimal medical therapy. And even after he got his initial PCIs, I don't think you reported an EF that was normalized or much better than 20, 30%. So to me, that's not the answer. Based upon that for this gentleman, I mean, it may be all microvascular stuff that's beyond this, the large epicardial vessels. Obviously I'm making it up, but I don't know that opening that is going to have a substantive effect on his prognosis. He already has a defibrillator in. He's on optimal medical therapy. He's relatively asymptomatic, although I would argue his CPET is inching toward badness. But yes.
Yeah, I mean, I don't see immediately any role for PCI, to be honest. If he's, totally asymptomatic as best we can tell. Granted, the CPET's kind of borderline. That's a little bit nervous. I keep a close eye on and make sure he doesn't decompensate in the intermediate term. But for right now, I wouldn't myself proceed with PCI. And the fact that he was fully revascularized, if I understood correctly, but the LV function remained poor. Well, the experiment's already been done, so there's no reason to think now that it would really change. There certainly are cases where, you can do PCI and CLV function recover. Back in the bare metal stent era, when I was at Cleveland Clinic, I remember a deacon from Michigan with diabetes, very, very obese, could have probably had cabbage, but he himself refused with severe PROX, 3 vessel disease, but 3 very focal PROX lesions where we had LV dysfunction. I stented all of them. The LV went from like 25% to normal. That was in the bare metal stent era. Everything re-stenosed, and then his LV got bad again. And I opened up again, and then it got better again. So, I mean, that was an anecdote, obviously, but, it's proof that in some circumstances it can work. I mean, there, I think if you had cabbage, you just went to do it, it would have been a more durable solution. So I do think there are cases where, revascularization percutaneously, certainly surgically, can improve LV function. But that guy did have angina. And Dr. Rogers did make the point, with diabetes, that's kind of out there that people with diabetes have more silent ischemia. That's true. But I still think if someone has diabetes and has angina and LV dysfunction, that's the person where revascularization is going to help. I think it's a little bit exaggerated, in fact, and probably reporting bias in the literature about, diabetes, they just have no angina. And just like that's sometimes said about older patients and women, it's true in all those 3 groups that I just described. There's a little bit more cardiac chest pain, but not that much more. That is, if you compare males to females, older to younger, diabetes to not diabetes, it's not some drastic difference. Most of those folks that have really bad coronary artery disease will have angina.
Thank you. So yeah, very quickly, this is a proposed way of thinking about ischemic cardiomyopathy and when to revascularize with viability. So first looking, to see if they're even suitable for revascularization, which we briefly talked about. If yes, maybe looking for some sort of ischemia. If yes, then consider revascularization. If not, then looking at the extent of scar on MRI. If less than 25%, maybe yes, revascularize. But if they are at that 25 to 50% range that we talked about, maybe looking for some evidence of metabolic or contractile reserve. And if yes, then revascularize. And if not, then maybe just stick with optimal medical therapy. And then finally, just going back to our case, so he was recommended against revascularization given the longstanding cardiomyopathy history preceding his overt CAD, and it was thought that maybe revascularization would not provide maximum benefit at this time. He was also for LVAD and heart transplant per the heart failure team, and he was discharged with a plan for just medical management. And he was recently seen in a heart failure clinic where he continues to remain well, active, and asymptomatic. And that is all I have.